Good afternoon, everyone, and thank you for joining us. Today's webinar is Navigating Nutrition Challenges in ICU Patients, a case-based panel discussion. And this will be presented by Michele ApSimon, Heidi Nixdorf, and Mignon Radhakrishnan. I'm Lauren Murch, a Medical Affairs Manager for Nestlé Health Science, and I'm your moderator for today's session. For the first part of today's webinar, we'll be discussing a case scenario about nutritional management of a complex neurosurgical patient. And when you registered for today's session, you may have noticed that we asked you to indicate an ICU nutrition challenge you feel is difficult to address. So for the second part of our webinar, we've grouped those responses into themes, and we'll have a discussion about the most popular topics that were submitted by those who are attending today's webinar. On the right-hand side of your screen, you should see a button for Q&A and a button for poll. During each part of the webinar, there will be some time for questions, so you can enter questions into that Q&A box on the right-hand side of your screen, and we'll do our best to get to as many of them as we can. And we also have a few polling questions during the case scenario, and you can access those from the right-hand side of your screen as well. I am honoring the land we are presenting on today. We respectfully acknowledge that Nestlé offices across Turtle Island are located on the traditional treaty and unceded territories of First Nations, Inuit, and Métis people. Indigenous peoples share a sacred relation with the land, and this acknowledgement is only the first step in learning more about our history and taking action towards reconciliation. Now, I'd like to introduce our speakers for today. Michele ApSimon is a registered dietitian working in critical care at the Hamilton General Hospital. Michele is active in the critical care community and has been involved in many research initiatives. She's been a guest speaker at conferences and webinars such as the Aspen Nutrition Science and Practice Conference and has been an author on numerous peer-reviewed publications. Mignon is a critical care dietitian at Vancouver General Hospital, and she's worked with critically ill patients for over 20 years and has been the dietitian for the BC Professional Firefighters Burn Unit since 2006. Mignon is passionate about education and research and is always on the lookout for innovative ideas for improving patient outcomes with nutrition care. Heidi is a registered dietitian who's been working in the ICU at Credit Valley Hospital for over 25 years and is a self-described volume-based feeding enthusiast. Today's session is being recorded, and after the session, you'll receive a certificate of attendance as well as a handout and a link to the recording. Financial support for this presentation was provided by Nestlé Health Science. The views expressed herein are those of the presenters and are accurate as of the date it was presented. And now, without further ado, with all of that housekeeping aside, I'll turn it over to Michele for introduction of our case scenario.
Thank you, Lauren. Hi, everyone. I think the goal today was to go through a case scenario and maybe have some discussion around the case, and just to show how a lot of us maybe do stuff differently with the end game of getting our patients out of the ICU successfully and with the least amount of loss of lean mass and maybe cognition. Anyway, so what we're going to do today is we're going to go through a case about a patient who, sort of a fictional patient, who would have been in our ICU. And basically, are we going to move forward, or is this just the first slide here? Okay, so it's the management of a neurosurgical patient, and I can't read those slides. Okay, hold on, let me see if I can make them bigger. Okay, here we go. We came to the ICU. So we see this a lot in critical care. We see a patient who comes in post brain tumor resection, but there's so many other complications. So she had a post-op seizure or seizures. She was in DKA. She had respiratory failure, and she's intubated, slightly sedated and ventilated. She's bacteremic. She has kidney failure, so oliguric, meaning less than 500 mils a day of fluid, acute kidney injuries, and she's fluid overload, and she's got pancreatitis. She does have an NG tube in situ, and incidental imaging found that she had cholecystitis, which we see quite often. Acute pancreatitis, probably secondary to a pancreatic mass that we'll talk about a little bit later. So she had pancreatic duct dilation and a mass. So you've got all these issues coming up with your patient. And so you sort of have to look at the whole picture before you assess them. And what do we know about her history? She had Hashimoto's or thyroiditis. She had celiac disease. And for the sake of, of nutrition, the chronic kidney disease and type 2 diabetes. Often when I'm charting, I don't put, I do relevant past medical history as opposed to listing it all, because sometimes we tend to overchart. She did have a huge weight loss, well, significant for her, but greater than 10% over the past 6 months. And remember, she's got some underlying, she just had a brain tumor resected. As far as labs go, the relevant labs, so of course there's a ton of other labs that may stick out at you, but for her, her lipase was high, she was hyperglycemic, and she had a high urea and creatinine, she had high phosphate, her potassium was quite normal, which also happens in renal failure, one's high, not the other. And her sodium was slightly low, again, a volume, just from too much volume. And the relevant meds that we're looking at for her, again, sorry, just having trouble reading these. There's no bowel meds on admit. We do have an ICU bowel protocol, which I'll talk about in a minute. She's on an insulin drip to minimize the gap, because when you have DKA, your goal is to close the anion gap. So she's on a drip with a little bit of D5. She's on antibiotics. Again, remember, she's bacteremic, so sometimes they don't know what it is right away, so they just throw them on a big whack of antibiotics. And she's on Lasix to try to stimulate her diuresis. So, am I changing? Are you saying? So what do you do when you look at this patient? You go look at them. You have to lift the sheets and have a look underneath to see if the weight is actually correct, because oftentimes you guys know that the weight stated in the computer is not their actual weight. So her height's 173, her weight was 55. She had a low BMI, and her SGA is C-ish. And I'm going to say C-ish because a lot of times you can't get you can get the physical information for your SGA, but you can't get, you don't know their history if the family's not around. So she's definitely malnourished on a med, and she's at risk for refeeding syndrome. Most of our patients that come into the ICU are high risk for malnutrition anyway, but then she tops it off with her weight loss and high refeeding risk. So how do you assess this patient? And the REE, it should be estimated energy there unless I'm measuring. We do have indirect calorimetry here. So when I do indirect calorimetry, I usually refer to it as the resting energy because I'm not guessing. For her at the beginning, we estimate, so it's 20 to 25 calories per kilo. And some of you, don't worry, we don't start at this goal with refeeding for her, but we may, depending on the patient. We can talk about that. And then for her protein, it's 1.3 or 1.5 grams per kilo, sort of a estimate of what her requirements would be. So what do we use? This is, I'm not sure if we're going to go into day 2 just yet, but I'm going to use a calorically dense semi-elemental formula. And the reason I do that for this patient is because she's got pancreatitis. She's also got acute kidney injury. So I'm going to give her less volume. I'm going to give her a semi-elemental feed, which I like to use in our patients with pancreatitis. I know some people say you don't need to, but I just find if you're minimizing digestion and allowing for just absorption, then it helps with the patient's tolerance to the feed. So again, it's helpful in the context of fluid overload and the pancreatitis. It does have some sugar in it, but we're not going to start at a high goal rate. Okay, so now we're moving on to the discussing the questions. So you
should see a poll pop up on your screen in a moment. And if you don't, you can also click on the right-hand side of your screen to go to the polls tab to be able to answer that question.
And while you guys are answering that, I'm going to ask Heidi and Mignon how they would start feeding this patient. Like, what are your thoughts?
Do you want to go first, Mignon?
Sure. Initially, looking at a patient like this, knowing that they're at risk of refeeding, I would start with a calorie per kilogram target. And then I would also have my calculations ready for establishing a goal rate. And once our metabolic cart is up and running, then that is something I would also add into my options for deciding what the patient needs.
Yeah, same. We haven't had a functional metabolic cart for a few years, but we're hoping that's going to change shortly. So in the past, she would have been someone that we would have targeted for indirect calorimetry, but currently I would have used a similar kcal per kilogram target for sure. And then I guess if I can go ahead and just talk about formula, because we did talk about formula. I guess I just want a bit more information because I'm the same as you, Michele. I actually prefer the Peptamen 1.5 for pancreatitis, but I would want to know a little more about her hyperphosphatemia, maybe a Novosource renal, like something initially, if her acute on chronic renal failure is bad. Now her potassium was fine, right? Her potassium was normal. So yeah. I'm not as concerned about phos as I am about potassium, but those are just some thoughts that I had.
Yeah, Heidi, I agree. I like the peptide-based formulas because they tend to be high protein, low carbohydrate, so it works well. But again, with the renal dysfunction, I would want to consider some other options. If I needed that 1.5, I would probably consider mixing a 2-cal polymeric with a 1-cal peptide-based formula, and then just assess from there, looking for things like malabsorption and adjust from there.
Right. And so while we're waiting for the questions, what you can do too is, so sometimes we do use the 1.5 semi-elemental for this particular patient in a renal, and then what we do is we'll throw in calcium. And oral calcium will bind any phosphate that's in the feed in an ideal world if you're giving enough. So, so sometimes that's sort of our backdoor way of treating a hyperphosphatemia.
Well, the other thing too that I kind of like that's not the right thing to say, but when you do have refeeding in a renal failure patient, sometimes the refeeding itself can help clear that phosphate. And then they are on an insulin drip. So an insulin infusion can help clear phos pretty quick too. So yeah.
Well, if we look at the responses from the attendees today, it seems like similar kinds of thinking. Around 60% of you have said based on kilocalories per kilo target. We have about a third of respondents that are also saying they would just go straight for a trophic rate, not based on a caloric goal. And then a minority of people saying indirect calorimetry or various predictive equations.
And the last thing is, if you don't have indirect calorimetry, I know Dr. Singer from Europe has a paper on using your just end tidal VCO2. So if your patients are intubated or ventilated and you ask your RTs if they can do the end tidal CO2, and you take the CO2 number, but the problem with it is it's a point in time, but you get a CO2 number, sort of maybe you can average it out, and then you multiply that by 8.19, which I believe was in his paper. But it's just like, sometimes I think what they're trying to do is get us to move more to getting direct actual numbers, because that supports our profession more, as if we have some sort of numbers to back up what we're doing. But anyway, just thought. So,
also gives a bit of a direction, to give you confidence in whatever strategy you're going with, right? Great. I will move to the next discussion question, which is what protein range would you target when determining protein requirements? And I think the intent for this question is, correct me if I'm wrong, Michele, kind of what you'd ultimately target, not necessarily what you'd start with right out of the gate.
Right. Because we all know the literature has definitely changed over the years. So we're all about feeding protein and everything from the get-go. And now we know that you slowly ramp up to goal rate over however many days. And again, this is patient dependent, right? So however many days you think your patient needs to tolerate goal weight. What do you do? What do you guys do? Mignon?
I think for a patient like this, I'd be looking in that 1.3 to 1.5 gram per kilogram range. I think generally when you start at a lower calorie per kilo target, you're not going to hit 100% right away. And then of course we'd make adjustments for other things like wounds or CRT, and just as we go along.
Heidi?
Yeah, same. I'd be around the 1.3 to 1.5 with the initial goal to stick around 1.3. Again, just also wanting to know more about our kidneys, and we're a renal center here, so we get a lot of people who are, they're kind of pre-dialysis who roll into the ICU, and it's not very often that a nephrologist challenges us, but they may want to see something closer to a 1 gram per kilo, or so 1.3 seems to be a good starting place in my mind.
Okay.
And again, knowing that initially when you start it up, they're not going to get that anyway.
Exactly. And I think sometimes we focus on that, what your goals are and how often do your patients actually get what you order, right?
Exactly.
So do you have answers yet, Lauren, or?
Yep, we've got about half of the attendees have responded so far, and it looks like kind of similar to what you guys are saying. About 2/3 are saying they'd target 1.3 to 1.5, and then about a quarter of people are saying they'd go for the 1 to 1.3 range.
Okay, and I think that's fair. And there are ways we can talk about later to see if you're giving too much protein or not enough. In the patients with, healthier kidneys, but it's sort of hard to do sometimes when your kidneys aren't functioning.
And somebody else in the questions has also just commented that potassium will still need to be monitored because the patient's on an insulin drip.
Absolutely. Yeah. Great. Okay, so should we move on to the next slide?
All right, we have one more discussion question. We've kind of grouped a bunch up at the front here, get all the audience participating.
How much protein do you aim for at the initiation of enteral nutrition?
Yeah, so in contrast to the last one where we're saying what would you ultimately target, we're saying now how would you start out in reality?
Okay, well, I ask you guys because in reality, I don't even think about this. Like, to be honest, like I'm not thinking of percentages. I'm thinking of let's start them on a low rate of whatever. It's all going to be underfed. I'm not thinking of a target protein requirement. But what do you guys think?
No, same. I'm not thinking of a target protein requirement.
I don't think I've ever thought of it in this way, but just naturally with whatever formula you're choosing, if I feel like protein is the nutrient that I want to focus on, I would choose a higher protein formula. But like you said, we know that patients don't get 100% of what we order. And so it won't be 100%. It's probably more like 50 to 75 anyways. With burns, I might be targeting higher just because of the wounds. But a patient like this, if I'm hitting 50 to 75%, I think that's a good target to start with.
Yeah. So it's a bit of a tricky question because I mean, if you're doing your assessment and you're focusing on a goal of protein requirement in the first day and the second day or the third day, then hopefully you only have like 3 or 4 patients.
Yeah, that's definitely not the case.
Yeah.
That's
right?
precision nutrition right there.
Yeah, exactly. What sort of answers did we get?
Yeah, votes are still rolling in, but so far it's looking like the majority, like around 40%, are saying 26 to 50% is what they go for. Followed by 51 to 75% as the next most frequent answer.
Right. Which is what you would do when you start feeding someone. You just start feeding slowly, right?
Yeah, so it kind of mirrors whatever volume targets or calorie targets you have as well.
Right.
Yeah.
I'd say the 26 to 50 kind of just happens by default for a lot of patients without really thinking about it.
Yeah, organically. Yeah.
That's a good word. All right. Let's move on.
Cool.
Okay, so in ideal world, this patient is started on an enteral formula at 20 mils an hour within 24 hours. Usually we try to start them within 24 hours. I don't usually go see somebody. Day one means that they came, day one of ICU stay means they came in yesterday, right? Like they usually, everybody, there's some interesting, anyway, for me, they came in yesterday. It's like they were post-op yesterday, today's post-op day one, right? Does that make sense to everyone? Okay, so enteral formula at 20 mils, start at 24 hours, and then multivite. So somebody who's malnourished, who's refeeding risk, it says below day 2 thiamine, but we would actually always start them on IV thiamine right away. And how much, some of you may ask, and like at Aspen, they all say it depends. Some people say 200, some people say 300 milligrams IV times 3 days. Pick a number. I think you're giving them a lot, right? A lot more than they're used to. So we start IV thiamine, we start feeding them, we give them vitamins to meet their DRIs. The formula provided a number of feeds. Again, I don't really worry about, it says 13 calories per kilo and 33 grams a day of protein for day one, with the goal being just to stimulate, all the trendy things. You're stimulating gulp, you're giving substrate for your splanchnic proteins, you're doing all the things, but it's not a nutrition. We're not providing them with enough nutrition, right? Yes. And this is our goal, because we don't want to aggravate refeeding and we don't want to overfeed because of endogenous nutrients. So you know that when your patients come in right away, they have all this breakdown of your glucose and your lipids and your amino acids, and so you have all these nutrients already being provided by your body. So that's why you don't want to sort of overfeed right away, right? Start at a goal rate. So anyway, we did 20 mils. The next day, this is day 2. We're continuing sort of trophic feeds at 20 mils. And then day 3, I'm sort of progressing slowly at 30 mils as electrolytes, phosphate, mag, and potassium sort of normalize. Again, this can be different based on the patient, right? Some people we think are going to refeed and they don't refeed at all, right? So again, you have to assess each patient individually. And so it provides around 20 calories per kilo and 50 grams of protein. And I'm going to ask you guys in a second what you would have done in this particular case. I'll just go through at day 4. Again, the extended lights have normalized, probably with help of the renal function, but the renal function is improving and she's now diuresing well, right? So I reassess the enteral feeding regimen to increase to pretty much her goal rate, right? And we don't really worry about if it's 25, 26, 24. They're all just numbers. They're going to be getting some calories, maybe from meds. She wasn't on propofol, so we didn't have to account for that in this particular case, right? So she's getting adequate formula from the adequate protein from the formula, but we did add, adequate is not optimal, so we did add whey protein powder, which it says 20 grams because the powder we have here happens to come in 10-gram aliquots, and it's whey protein. So she got about 1.5 grams per kilo, which might be aggressive for some of you with recovering renal failure, or might not be. The insulin drip, so once we closed the gap, and she wasn't on insulin at home, but she obviously needs it now, then what we do is we discontinue the drip. Often we put them on a long-acting. Sometimes in this particular case, they change to a sliding scale. They figure out how much she needs, and then they do long-acting later on. So there's all sorts of different methods to do your insulin. That's what we did for her particular case. So currently we continue with the calorically dense amino formula because of the pancreatitis, the mass which is being investigated, which we'll talk about in a second, and fluid restriction it's not really necessary because of the increasing, the resolving AKI, but we kept it on. So back to you guys. So what would you have done in this particular case? Differently? The same? Mignon?
I might have taken a slightly different approach just because I would have used a kcal per kilogram target right at the beginning. And I probably would have been comfortable with a 20 kcal per kilo start using a low carbohydrate formula. And then we do daily blood work. So we're checking extended electrolytes. We also have an electrolyte replacement protocol, which our nurses can initiate. So as long as those are being replaced, I would probably feel comfortable, same kind of thing, progressing over 2 or 3 days up to a goal rate. And we would also do the multivite and the thiamine right from the beginning as well.
And Heidi?
Yeah, I would have, in her situation, would have started at around, I guess a little different or maybe similar, about 50% of her estimated requirements.
Yeah.
And then similar, we have like electrolyte nomograms or protocols, so we can monitor those. The nurses can replace. We start everyone on a multivitamin. With thiamine, depending on the doctor, but most of the time we do 200 milligrams a day for a minimum of 3 days. And then depending on what we see in the rest of the electrolytes, like if your phos continually is low, if it looks like they're still refeeding, we might just continue the thiamine until we're confident the refeeding is kind of over. Again, and I want to say that sometimes it's just really difficult to distinguish what's refeeding and what's actually like losses through CRRT or losses through insulin or losses or intracellular shifting with insulin or losses with diuretics, but that's kind of besides the point. So yeah, multivitamin, thiamine, and then it depends what I see the next day. If everything looks good the next day, electrolytes are good, I might go straight to, her goal volume. If it looks like, things are stable. If not, then I might do an incremental increase. So, up to 75% of her requirements. If things look really bad, we just hold, where we are and try to correct everything.
Perfect.
And that kind of aligns with one of the questions we had from the audience was how many days you would wait before advancing past that initial phase of critical illness. And I think the answer I'm hearing is it depends.
Yeah, everyone refeeds differently. Yeah. Like everyone goes through their acute phase, late acute phase, whatever, differently. Like, it's nice when you see it on paper in the journals or in the guidelines, but annoyingly, the patients don't follow those rules. And so, you can get a prolonged acute initial phase. So, yeah.
Yeah. In a similar vein as well, one of the questions from the audience is, would you continue to provide that daily multivitamin once you get formula up to goal or only before you get up to goal?
I just leave it on.
Yeah, same. You have to watch too, because if there is propofol, I know in this case there isn't, or for some reason you can't give enough feeding formula, then you really should have a multivitamin.
Yeah.
It's a low cost intervention. It's unlikely to cause harm.
Yeah.
Exactly.
All right. We'll move right along.
Okay, so this patient actually was found to have a pancreatic mass, and we don't often do this in the ICU. Usually we get them out of the ICU and then bring them back for surgery, but this particular patient, she's been well fed for 3 or 4 days, so she's still mechanically ventilated, so she still needs nutrition support. Her pancreatic mass is identified, right? And she's now scheduled for a pancreatectomy, but not probably for a few days. So what do we do now? Because she's pretty stable and ICU stable, right? So she's not on I didn't mention it, she's never on pressors, right? And she's otherwise fairly stable. We know that her lipase is high, her glucose, 12 to 17. I hope you guys do a better job of keeping blood sugar than we do. It's dependent on the day, I think, but again, it's a big bane of our existence, right? We really try to get them to do better glucose control because we know variability is bad for outcome. She's got acute on chronic renal failure resolving, and so she's got good urine output, and her numbers are getting better, her urea and creatinine. if you want to go to the next slide, Lauren.
Mm-hmm.
So we're sort of optimizing her per surgery. We don't usually do this in the ICU. That's your surgery job. But what we're doing, and I know a lot of you may have an issue with this, but we actually have started doing this more here, is we intermittently feed our patients, and not when they're hemodynamically unstable, and not if they're on a ton of narcotics and we can't tolerate the volume. But as they can tolerate volume, we change to sort of an intermittent schedule. And so I would say for this particular patient, when I mix the feeds, and sometimes I mix the feeds, and Mignon, you were talking about this earlier, you mix like, polymeric and a semi-elemental or whatnot. This particular case, I mix them to add fish oil and higher protein, and less volume, continue with less volume, so I can do intermittent feeding, but I don't have to add modular proteins. Sometimes our modulars don't get given, surprise, surprise. And I can feed 3 times a day without giving too much volume. So with her, we changed the intermittent feeding schedule with long and fast-acting insulin prior to for better glucose control. So what I mean by that is normally with diabetes, you give insulin when you're eating, right? You take a bolus of insulin right before you're eating your carbs. Well, this is sort of the same sort of premise. So for her, we get pretty decent control when we do that in here, if they're stable. So I mixed the 2 feeds, sort of provided her with lots more energy, 30 calories per kilo. Again, we always look at if they're ventilated, we do follow CO2 and make sure we're not overfeeding. We follow with the cart to make sure we're giving them sort of what they need. So I can tell you the underweight and the obese patients are always done on the metabolic cart because we can't really guesstimate what they need. We've given them protein, and she's still getting carbs. Like, it's 180 grams of carbs. It's quite a lot. But with this particular patient, we were able to manage it. So it's 3.3 grams per kilo. So you want to go to the next slide, or do you guys have something to say about? Oh, okay. Would you guys ever use intermittent feeding in your ICU? I would take bolus out because I'm pretty sure nobody does bolus feeding.
Yeah.
Not in ICU.
It depends. We have ALS patients in our community that come in. Like, I know this is a real one-off, but
right.
They'll come in and they get a pneumonia, they get something where they end up, on a lot of these patients are on home vents, but they come in, they get put on a hospital vent, they're awake, they're alert, they're complaining to me that they're hungry. So they really don't fit into any of the guidelines, and they're asking for their own bolus feedings, to resume as usual. So it's very rare, but sometimes our patients will resume their previous feeding, and it's bolus, so they're syringing it in, or their caregiver is. Yeah.
Okay.
We wouldn't probably use intermittent very often in our ICU, but definitely the times we've done it, it's been prompted before, usually by our endocrine service, asking us to try it for better blood glucose control. Bolus feeding, syringe feeding, things like that, might do in our step down or our high acuity areas, probably not in our ICU though.
And yeah, I just wanted to add too, like, for the patients who they're becoming more stable, we'll go to like a 12-hour daytime feed. So which, kind of works into getting back, resuming a normal circadian kind of physiology and, hopefully preventing delirium. So we'll go to a 12-hour daytime feed.
Okay. What about the audience? What did they say?
We've got about nearly 3/4 saying that they will use intermittent feed some of the time, at least.
Okay.
And then the other 1/4 or so saying that they don't.
Okay. And that's fair. And also intermittent, I think, would be, or is that cyclic?
I don't know.
It'd be 12-hour feeds, right? Okay.
We were calling it like by the wrong name, I think. We've been calling our 12-hour daytime feed like an intermittent feed, but then I saw the clocks on your presentation last week and I'm like,
yeah.
oh man, we've been calling it the wrong thing.
I know.
Which, when you think about it, like we cycle TPN. When we do a cycle TPN, you know, the 12 hours or whatever,
Right.
we name it by that. But for some reason, when we do a 12-hour tube feeding, we've been calling it intermittent. So we got to get our terminology straight.
Yeah, it doesn't really matter. Probably not.
No.
And we do have one comment from the audience that they'll sometimes move to intermittent if the hemodynamics improve and they're off their drip, and also to help with blood sugar control. So some of the comments from the audience are kind of in a similar theme.
Okay. All right, you want to go to the next slide? If we can get there. So our weight. Let's talk about weight. So it says her weight prior to surgery was 57 kilos. There's no way she gained weight when I had her. But you know, it's got to be fluid or it's an inaccurate weight. But it didn't drop significantly down, which is a win, right? Her blood work is stable-ish, right? So her hemoglobin, albumin, transferrin, they're not decreasing. So, you know, do we follow albumin? No, not really. But if they're not decreasing, that's always a good thing. A nitrogen balance we do in the unit, and I like to use it as a number again to show the team they're in negative or positive balance. Not usually in patients who are in renal failure. Her kidney function is improving, so we could have done it in the end, right? We missed the whole surgery part there for the sake of time, but she had surgery. She tolerated it. She had a pancreatectomy. And so the problems with losing your pancreas, again, are that you have no insulin. So you're essentially type 1 diabetic. And again, you have exocrine and endocrine insufficiency, so you'll need enzymes. So don't forget, because I'm going to say we resumed enteral feeds TID, but what we do is when we do the intermittent feeding again, we'll do it slowly. So post-op day 1, we might start out like 100 mils TID and then work up to 200 mils times 2 hours TID. So make sure they tolerate it. And then now forever, she'll be on long and fast-acting insulin. And then she's weaned to extubation, and you're thinking, wait, you forgot she had a brain tumor resection. I didn't forget. She's tolerating diet, but what we do here in the unit is we have incorporated into our EPIC is a stand. It's like a bedside swallowing tool that we get every nurse to do on every patient after they're extubated. So they'll figure out if she can tolerate food. So they get applesauce and they get water through a straw. And if they fail that test, then they generate an SLP consult. But she did okay with a diet, so that's great. So we gave her a diet with pancreatic enzymes. So pancreatic enzymes, we usually get about 1,000 units per gram of fat, and they can tolerate that fairly well. And then she has her insulin. So I think that's sort of it. I don't know, what would you guys have done differently at that point? Or
Not much.
Not much.
Okay.
No,
Okay.
same. We do a similar swallowing, like a nursing swallow assessment after. That'll either doesn't automatically generate an SLP referral, but we typically get them if we need them. Yeah, we don't do nitrogen balance here, unfortunately.
No, neither do we.
So,
Yeah.
but yeah, everything else looks similar.
Okay.
I was going to say that 57 kilos, is that dry? Is that wet?
Exactly.
What is
definitely
that?
wet with a couple pillows on the bed. But
I was going to say, what was on the bed?
Was it a pillow?
Absolutely, 100%, but I'm going to take it as a win.
Yeah.
So why do I mix feeds? Again, you can get way more options if you mix feeds. I think you guys do that too. So, you know, you can mix your calorically dense semi-elemental with something with omega-3s and higher protein. You can get a little bit less volume. So again, you can tailor your feeds more when you're mixing feeds. So I think that's a beneficial thing to do, and it gives us more options. And it makes your job more interesting because you can do different stuff.
Yeah, I don't think I do it enough. I think this is something I'm going to look more into going forward.
Yeah.
Something we do a lot of in our ICU for exactly those reasons. It gives us a lot more options, and you can tailor what you're doing and make the, sort of take advantage of the features of different formulas.
Yeah. And, I mean, in the old days, I said, like I talked about this last week, if you watched that talk, but about fiber in the ICU, and times are changing. And so you might want to add a little bit of fiber. So you get some fiber by mixing the feeds, but not too much, that sort of thing. So again, intermittent feeding, it says that they can benefit, may optimize muscle protein synthesis in healthy patients. We know intermittent feeding, like 3 times a day, is the goal, right? For if you're healthy, and we know there's no data on this in ICU patients. But as your patients are getting better and they're walking around, then feeding them 3 times a day just seems to make sense, right? And so hopefully someday we'll have data on this. But right now we don't. But providing protein 3 times a day is never, or 4 times a day is never a bad thing, I don't think. Enabling better glucose control, we talked about that. The other thing is really beneficial. If you're giving your patients pancreatic enzymes, you want to give the enzymes with the food. So unless you figure out a way to give enzymes like 24 hours a day, then intermittent feeding is a great way to make the enzymes work, right? So I know in semi-elemental feeds, they're giving enzymes more for the long-chain fats than anything else, right? But still, intermittent feeding is helpful in that way. And then altering the feeding schedule may be a good strategy for managing diarrhea. Oh yeah, that's my last, just throw it in there. Many people will be like, what? You feed 3 times a day and you have less diarrhea? I'm like, yeah, try it. What happens is you have a certain amount of volume at the ileum, called the ileal break. You need to reach a certain amount of calories or a certain amount of fat or carbs, depending on what paper you read again, but to actually stimulate feedback to your stomach and to your brain to slow things down. So if you are always feeding continuously 24 hours a day, again, this may not stimulate that ileal break. Food for thought. So.
One of the questions from the audience, this is going back about 10 minutes or so, but in terms of ramping up the feeds like you did in this case, like if we take the refeeding risk out of the equation, how would this look differently for a patient that isn't at risk for refeeding syndrome? Like, are you following the aim of like 70% of resting energy expenditure for the first 3 to 7 days, or what would that look like?
What do you guys do?
Depends on the patient.
Exactly. Yep.
Yeah, it depends on the patient. So, and oftentimes, we'll assess somebody when they first come in at 20 calories per kilo. So they might be fed 100% of their goal rate, but they're only assessed at 20, right?
Exactly.
So,
yeah.
So I think it really depends on each patient. But yes, we're definitely going, if they're hemodynamically unstable patients, your goal in the first 2 to 3 days is to, make sure they live, and just maybe trophically feed them. Like, don't worry about a number. Just, you can slowly increase if you want. If they don't want, just, give them something to stimulate blood flow to the gut. And then when their pressures start to go down, their sedation starts to go down, then you can go up with your feeds. So it's so different based on each patient.
Yeah, I think that's a good guideline for what not to exceed, like looking at it from that way. But, just to give an example too, I just had a patient earlier this week, on Monday admitted, and we're a renal center. He's a dude that doesn't always like to do his dialysis. He skips it here and there, until he gets to the point where he's drowning in his own lungs and needs to come in for vent support while they aggressively dialyze him. But no other issues, no hemodynamics instability, like glucose is good. Everything looks good. It's just they need to remove water off, and they need to remove a lot. And so, I don't always feel compelled in that kind of situation to start low and ramp up slow. I'll be a little more aggressive in a patient who, maybe looks like that.
And I think also you keep in mind, patients don't receive 100% of what we order.
Exactly.
And also things interrupt feeds. There's procedures, there's ORs, there's unexpected events. Somebody turns down the feeds because the residual was too high, even though it wasn't. And So realistically, it takes a couple of days to get to that goal rate anyways. So even if you went for something higher, you're probably not achieving it in the first 2 to 3 days. And I know Michele earlier said, there's people that we expect to refeed that don't, but there's others that you don't think they're going to refeed, and you're seeing their electrolytes tank. So a conservative start is never a bad way to go, and a couple of days to get to goal is very reasonable without having a hard and fast rule for it.
Yeah, I agree.
We also had a question about the enzymes. Are you going for 1,000 units of lipase per gram of all fat, or just the long chain fats in your feeds?
I just don't worry about it. I just, I do all fat, but yes, I get it. It's for long chain fat, and it's 1,000 to 1,500, which is what our CF people do. International units of lipase per gram of long chain fat, right? Because MCTs don't need, they skip your lymphatics, they get directly absorbed, so you don't need enzymes for that. But it's just too much minutia, right? So we worry about the fat, we give them the enzymes, and if they're helping, if they're not helping, we may double it, right? So we don't get worried about the little numbers. What about you guys?
Same. We usually start somewhere. I don't know. I'll try to do the same thing where we'll try to get a patient maybe onto a bolus mealtime feeding, intermittent, or I think we're calling our intermittent bolus. So we'll do, and then get the enzymes. But really, we titrate the enzymes to the malabsorption that we're seeing. So, yeah.
Pick a place to start, and you adjust based on what's happening for the patient in front of you.
Yeah.
Great.
Is that the last one, or are they?
Yep, we have the references slide, and then that's it. So maybe we will shift gears now and talk about some of the hot topics that were submitted by our attendees of today's webinar. And the first one, the most frequent kind of theme that we observed when we looked at those registration responses was around held feeds and stopped feeds and feeding interruptions. So I'm just curious to our panel how you manage feeding interruptions and possible feeding contraindications or challenges getting the feeds going. And I know, Heidi, you're the volume-based feeding expert, so I'm looking at you.
Not an expert, but that was actually what drove us to adopt volume-based feeding was, people who've been around for a while know about the International Nutrition Survey. So after doing several editions of that, we were able to identify the fact that our feeds were being held for spontaneous breathing trials and extubation trials, for bedside procedures, for trips to CT. And there was, what we tried initially to do was try to manage things by managing the interruptions. And that didn't work. So we had a good protocol, we revised it, but trying to manage the interruption did nothing. And so the next logical step was to manage the actual holding of the feeds, right? So what volume-based feeding is, for anyone who doesn't know, it's any kind of feeding protocol where the nurse is able to adjust the tube feeding rate throughout the day to make sure that the goal volume that's prescribed is delivered within a 24-hour period. So at the time, we adopted the PEP-UP protocol, which if you go to the literature, there's all sorts of different types of volume-based feeding protocols. So, it's good to look at them all if you're interested in this topic, get a sense of what might work for you. And at the time, that seemed like a good option. I was also invited to be part of the PEP-UP collaborative, which helped me to implement it here, so that helped. But really, that's what we needed. So we needed a way for the nurses to be able to adjust the feeds to make up for the time that the feeds were held for the interruption. And so we went from, on average, giving our patients 50 to 53% of their protein and energy requirements to above 80. So, and I just want to point out that even with volume-based feeding, we still don't get to 100. So, but that is definitely volume-based feeding is definitely a great way to kind of overcome some of those challenges where feeds are held for things that aren't like vomiting or ileus or GI bleed.
Yeah.
Yeah,
I would say ours is a lot of education, and the fact that we're on rounds, we're working with our teams and our nurses, and we do have protocols for gastric residuals, which we're still using in our ICU because our patients are ventilated and are not able to communicate with us necessarily about things like nausea. We have algorithms for diarrhea management as well. And just that constant reinforcement that we want to feed, we want to get to goal rate, and trying to use objective data so people aren't stopping feeds because they think the patient might not tolerate, or things like that. So it's very much an education focus for us, to keep pushing sort of those principles of nutrition and why it's important for our patients, and using data, not our perception of, say, intolerance, to guide our feeding.
I think that's a really good point, Mignon, is the education. Like it's a never-ending narrative.
Mm-hmm.
Yes.
And I think we also have an algorithm or a protocol for managing gastric residuals. I know that's not supposed to be a thing, but it is a thing. And so if it's going to be a thing, then you might as well have something, to guide everyone in order to minimize the time feeds are held for residuals. So
yeah, we take every opportunity to promote nutrition and to explain it and to educate, and we're an outspoken group, so we enjoy doing that.
Yeah, I think too, I mean, you guys have a residual protocol. I think in here what we did is we just stopped measuring them. And the thing is, if the nurses feel abdominal distension and they feel like they're worried about it, they'll do a residual, right? Because that's part of their assessment. But we stopped making it, so nobody does residuals anymore. That being said, still people do them, but it's not part of they don't have to do it. And the other thing we have here is in the past year, they came out with NPO guidelines. So our intensivists sent out a message just saying there will no longer be feeds held if they're trached or ventilated, they have a cuff in. You don't hold the feeds for extubation, and for procedures, you just suction. And then unless it's tracheal manipulation, if they're doing airway manipulation, they hold the feeds for 6 hours prior to going somewhere. But I don't know how we only got that. We asked, and finally one of our intensivists took it on, right? Doctor to doctor. But he sent it out, and now it's part of our protocol. So you don't hold feeds for procedures. And so you don't get that ortho patient who's going for a wrist surgery being NPO for 4 days, right? And if you do, you go show the paper to the ortho residents and you say, no, you can't do this. So,
we have a similar arrangement with our ICU and anesthesia, and it's been in place for several years, actually. But again, that education piece, you get new residents, they rotate through, they're used to something different in another hospital. You get new nurses who aren't as familiar, and we get blips along the way, but we have a pretty good track record with that as well.
The one thing we've been able to do with our volume-based feeding protocol is feed up until the time, a surgeon may want feeds held, if that's going to be a thing. So you can ramp up the rate through the day to make sure that by the time the feeds are going to be held, they've actually gotten their 24 hours worth.
Yeah, I like that frame of thinking, like instead of catch-up feeds, you're kind of proactive.
Yeah, you're actually proactively putting them in there.
Yeah.
That's great.
We do have a question from the audience about going back to mixing formulas. Do you ever get any pushback from nursing about increased work to manage that? No,
not at all.
No, we have it built into our Epic. When we got Epic, the computer system, and we have the option to mix 3 feeds, which I've never done. No, I mean, this is what they do. They take 2 cans and they go like this. How's that more work? And the new pumps we talked about last week, that we're being sort of forced conversion, but the new pumps have it built in that you can give a volume and you can say, you can do intermittent feeds and mixing feeds, not mixing feeds, but intermittent feeds. So it's a bit easier that way. But no.
I need to talk to you, Michele, about your EPIC situation, because our EPIC situation doesn't sound as slick. So to get 2 tube feeding formulas to actually be delivered to the patient, we can do it, but it's very awkward. So I'll have to talk to you later.
Chat offline.
Yeah.
Yeah.
Ours is stocked in the ICU, so we're able with our computer system as well to put in that mix into the order, and then they can just take it off the shelves. So we're not actually waiting for someone else to deliver it to us.
That's great.
More questions, Lauren? We have a few more minutes.
Yeah, maybe I'll jump to the next topic that was submitted in the last couple minutes. So the other kind of frequent topic that people submitted was around meeting feeding goals and determining feeding goals, particularly at the extremes of BMI. So thinking about both your very underweight and your very overweight kind of patients.
You guys want to go? I sort of said we use the cart in those extreme patients. So what do you guys do?
We will use the cart for sure, for very low BMI and also very high. I know we also will do adjusted weight, and we've just agreed to be consistent about how we do that amongst our ICU group. I mean, everybody does that differently. I think the important part is that you choose a path and you are consistent about it with your team. And a lot of it is like everything we do, you start with a target and you adjust based on the clinical situation.
Yeah, in the past, we used a metabolic cart, and in the future going forward for the extremes of body weight. And for now, like for anyone who is underweight, we use their actual weight. I know in some papers and some places I've seen adjusting weight for underweight, so I've never done that. And then adjusting for obesity, I tend to default to an ideal body weight at a BMI of 25. I started adjusting weights. You know, I don't know if anyone remembers way back, Aspen had an app. It was like the Aspen workbench, and you could adjust body weight for edema and for adipose, and like you could adjust for all sorts of things. And in the end, what number do you have? Like it's just a number. So I just felt I'd go with ideal body weight, and that way it's not, influenced by edema, and that's my story.
If we're not using the cart, again, we are very skeptical of the obesity guidelines now. So because we've had our student look at a bunch of patients with different BMIs, and they need a lot more calories than what 11 to 14 calories per kilo is. So often we do 14 to 18, 18 to 21. Sometimes I don't adjust at all for a BMI of 30. Or like 30 to 35. It depends on the patient and their lean mass, if they're fit, or if they're mobile or not mobile. But again, it's, every patient's different. And so you sort of have to assess them based on where they're at that point in time.
Yeah, I was gonna say, like, you have like your BMI and like your numbers, but do you ever adjust based on, say, gender or what you think their body composition is?
Yeah,
yeah, sometimes, because it's a good point, because I had a few years ago, we had a really big guy. He was 30, he was about 800 pounds, but he was able to haul his 800 pounds around. So he had muscles under that weight, so he had some muscle mass, where a lot of the other obese patients we have are sarcopenic, like they're bed bound, they're obese, and that I do try to think about those things when I'm calculating. And again, I still don't know what I'm doing. Everything's just an estimated guess. But when I say I use ideal body weight, I'm actually using the 22 to 25 kcals per kilogram of ideal body weight, which I think, as per Aspen, it's meant to be for anyone with a over BMI 50. Over 50 or something. Yeah. But I just like those numbers.
Yeah.
The other group to be just aware of is the ones who are quite muscular. And so if you just do a BMI, it may be well over 30, but I wouldn't adjust for a patient like that, because it's lean mass that's in that in front of me.
Exactly.
So I'd want to use an actual weight there.
Yeah, so take it with a grain of salt in some of those people. In the last minute, we do have one other question here. Maybe we can get off the list pretty quick, but with the volume-based feeding, Heidi, do you find the nurses are coming to you to ask what to increase the rate to, or no?
No. So part of the volume-based feeding protocol includes a table. So it's an adjustment table. So and ideally, what the nurse does is she zeroes the pump at the beginning of the day, or the beginning of the shift, I should say. And so the pump starts at 7. Or 7 a.m. in the morning. And as the day goes on, if the feeds are interrupted, the nurse can go back, check the volume that was delivered. And then on the chart, you can see what you need to figure out then is how much, roughly needs to be delivered for the rest of the day, and the time you have remaining in the day. And then the table will tell you what to set the feeds at. So it's a pretty slick table. I didn't design it myself. And before we actually started this webinar, I did quickly go on the Critical Care Nutrition website, and all of the tools for implementing PEP-UP are still there. So you can take a look at the table that was designed to help nurses adjust tube feeding infusion rates. And again, PEP-UP might not be the protocol for you, but a lot of the tools that come with it are really good. Like they do have a tool for how to create, guidelines for gastric residuals, guidelines for managing diarrhea. So all those other things too that contribute to feeds being stopped. But short answer is we have a table. So they don't come to me.
Because that's how I first met you, is talking about these things.
Yeah. And you know what? If I had to have designed all that stuff myself, this would have never happened.
Yeah. Well, and I think you bring up a good point that you can kind of pick and choose, like even if that protocol out of the box doesn't work for you, you can pick and choose elements of it to implement.
Yeah. And the table itself really just is volume and time. So the table that was designed for PEP-UP will fit with any PEP or any volume-based feeding. So you don't have to recreate the wheel.
Any final comments, Michele or Mignon, before we're a few minutes past the hour already?
No, I'll just say keep talking, keep learning, keep reading. Remember, what you learned in school is probably 50% of it is obsolete after you leave school. So let's keep talking to each other and trying to make change happen.
We're always learning, all of us. Those conversations are so important.
Yeah.
Well, I would like to thank the three of you for sharing your knowledge and experience today. This has flown by, this conversation. And I'd also like to thank our attendees for their engagement. We got lots of questions, and I'll try to follow up with some of the ones we didn't get to today. And we'd appreciate if you could take a few minutes to complete a brief feedback survey. So if you look on the left-hand side of your screen, you'll see a forms button, and then you can submit a really quick survey there. And also, I'll just remind everyone that this session was recorded. And once the recording is made available, you'll receive an email which will include a link to the recording, as well as the session handout and a certificate of attendance. So this concludes today's webinar, and I hope everyone has a fantastic rest of your day. Thank you so much.
Thank you.
Thank you.
Thank you.